Welcome to today's program, Clinical Success is Spelled IT. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare. Today's program is sponsored by the Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we have a few details to share. The way to move the windows on your screen is by clicking and dragging, or you can enlarge and minimize the windows by clicking on the icons in the top right corner. Please use the Q&A area to the right of the slides to submit a question for our presenters at any time. You don't have to wait until the end of the presentation. But if you can't see this area, simply click on the red Q&A button. You might want to download a copy of today's presentation, so please click the link in the resources area in the lower left of your screen if you'd like to do that. If you have any technical issues during the program, please click on the yellow Help button, and we will definitely help you troubleshoot the issue. Finally, you can also tweet during today's webinar by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag BHLiveWebinar. At this time, it's my pleasure to introduce our speakers for today's program. Joining us today, we have Chris Thompson, Senior Clinical Operations Director for Monarch, Jason Cagle, HIT Manager for Monarch, and Larry Smith, COO of Grand Lakes Mental Health. Thank you all for taking the time to speak with us today, and with that, I will turn the audience over to you.
Thank you, Julie. This is Chris Williams from the Echo Group. And before we get started into our program, I just wanted to take a moment and share a little bit of preliminary information. First, we're thrilled to continue our partnership with the folks at Vendome to continue bringing these informational webinars to you folks, and excited about today's program. Just a brief bit about the Echo Group. The Echo Group is located in Conway, New Hampshire, where the fall foliage is absolutely perfect this time of year. We've been in business since 1980, so we're in our 35th year, and over that time we've worked very hard to empower our partners in behavioral health care to be the most clinically effective and financially strong. And we offer a suite of services and products designed specifically for behavioral health care, and are looking forward to doing that for many more years to come. With that, I want to share a little bit of information regarding today's presentation. A week or so ago, we hosted our what we call our peer-to-peer summit in Portland, Maine. And that's annually a group of customers come together for 3 days of peace, love, and software, and talk about industry things, items about our software, and things of that nature. But one of the things that really resonated with us and this group of folks this year was the idea that software and technology in particular transcended traditional roles with regard to behavioral health care. We see any number of examples of organizations across the country who are leveraging technology to do pretty remarkable things with their organizations and, of course, the communities that they serve. So with that as a sort of a framework and a jumping off point, I'd like to turn things over to Larry Smith, Chief Operating Officer at Grand Lakes Mental Health in Oklahoma, and he'll share with you his information and the story of the great work that those folks are doing as well. So, Larry, take it away.
Hi, my name is Larry Smith. The Infinity and Beyond is a title that we came up with. Actually, a gentleman from Echo came up with, but Infinity and Beyond to me means that we're outside of the box. We have moved outside the box, and there is nothing that is stopping us from doing what we need to do for the consumers in Northeast Oklahoma. So with that in mind, we started providing integrated care. And this program is going to be about how we did that, how we used IT to do it, and what we're doing presently. The need for integrated care was very obvious in the nation with 5-year average death rate for the SMI population earlier death rate for the SMI population being a major concern and something that we need to deal with. And so we decided that in rural Oklahoma we would do integrated care. Integrated care means a lot to many different people. To me, it means that we have the wellness program, the health care, and the psychiatric care for our consumers located in one location, documenting everything in one electronic medical record. So all providers, all therapists, all case managers have access to the record. We looked at the need. We came up with a plan, and then we brought that plan into a reality. And that's how we do things, and we do that outside of a box where we don't say that we have to do things a certain way. A mentor of mine one time said a good idea can come from anywhere. I didn't know if he was insulting me because I just said something, or if he was saying that a good idea could come from anywhere, including me. So after years of therapy, I decided that he was not insulting me. He was, in fact, telling me to listen, because a good idea can truly come from anywhere, and we can take those ideas and turn them into realities and make us and do anything that we choose to do. We're doing fully integrated services in 8 sites in 7 counties in northeast Oklahoma. How we got started, we assessed the need of the consumers we serve. And then we had to confirm our desire to address the need. And when I say confirm our desire to address the need, to me, that says we refuse to fail. If we're going to start it, we're going to do it, and we're going to make sure that it works. So we had to do some things. We had to look at the demographics of who we wanted to serve. We wanted to look at the outcomes that we wanted to reach. Not only when I talk about clinical outcomes, key performance indicators, I'm talking about not only just the clinical outcomes of the CAR scores and other type of scores, but also the medical outcomes. Is the cholesterol level dropping? Is the blood pressure where it should be? Is it within range? And we also have to have a financial outcomes, of course, because we must continue to operate. Workflow had to be reviewed. We had to look at all of our resources. Resources are in the community, and what resources that we need to create. So how does Grand Lake Mental Health provide integrated care? What's not mentioned in this first of this slide is integrated care includes pharmacy. If your pharmacy is not part of your integrated care, if wellness is not part of your integrated care, it is not just the medical treatment and the psychiatric treatment. It is wellness, it is pharmacy, it is the community, it is also housing when you're truly doing integrated care. We have a board-certified psychiatrist that supervises 3 nurse practitioners because we are in 8 locations. And the nurse practitioners are trained in family medicine. The board psychiatrist sees all of our new consumers for their first visit and prescribes any psychotropic medications as needed, also reviews the treatment plan and the diagnosis and the assessment that was done by the LMHP that did the intake. Nurse practitioners provide both psychiatric and physical examinations during each medical visit after the initial psychiatric visit. So that anytime the consumer comes back in, they're going to see a nurse practitioner. We're going to do physical health as well as mental health in the same visit. The psychiatrist is available through telemedicine to consult with the nurse practitioner if needed. Our nurse practitioners over time become very familiar with our consumers, very familiar with the psychiatric medications that they're taking, and so not every visit is a consult with the psychiatrist. Of course, any time that we do Schedule 2 medications, the nurse practitioners will consult with the psychiatrist to assure that the Schedule 2 medications are being written by the psychiatrist. Our nurse practitioners are not allowed to write Schedule 2 meds based upon their credentials. All documentation is concurrent, and this prescribing is completed through the electronic medical record using Dr. First for through electronic prescribing. We also in Oklahoma have the ability to prescribe Schedule II meds. Our board certified psychiatrist through a token, and so none of our prescriptions have to be written unless the consumer chooses not to use the contracting pharmacy that we work with. So that's basically how we started and what we're doing today with our integrated care. What's next for us is we're recognizing more and more that our clinic's mental health is not something that starts at 8, stops at 5, Monday through Friday. We're opening our clinics 24/7. Our first clinic will be open 24/7. Our first clinic that we're opening 24/7 will be open hopefully sometime in November. We set November the 1st, but I don't believe that we're going to hit that date. But we will have our clinic open. RN and LMHP and RSS, recovery support staff, will be operating in the clinics after hours and on weekends and holidays. The living room model is designed that we have designed is allowed for consumers to volunteer, stay up, and so we can triage them and they can volunteer and come into the unit until they stabilize, and that would be part of our 24/7 clinic outpatient service. Families and peace officers can assess and bring consumers to the clinic. When an emergency is psychiatric related, bypassing the ER and hopefully stopping the inpatient stay as it is our most expensive care. One of the things that we had to figure out is what do we do with a consumer when it's time for them to go home? Make sure that they're safe, make sure that they can still contact us, and make sure that we can stay in communication. And we're using the iPad technology for that, and so consumers that will be leaving this 24/7 unit, as well as consumers that's living in extreme rural Oklahoma in our catchment area, will have iPads that we will be furnishing for them, and also that all they have to do is touch the camera on the iPad, and we'll be able to contact us, or we can call them on the iPad and talk with them face to face. What's the common thread? What makes it all work? The executive team needs it. I can tell you that. You got to have it on your executive team. You have to have it. It builds a foundation for scalability. It drives efficiency. It affects your sustainability. It stores the data. It reports the outcomes. It expands the possibilities of your buildings, of your staff, and the ability for your staff to meet the needs of your consumers. It is information technology, so it is IT. So that is the basis of where we have built, and it is where we are headed, and we know that it is what will drive healthcare down and efficiency and effectiveness of healthcare in an upward movement. I met a couple of guys at the ECHO workshop, and they're from Monarch, and I am going to turn this over to Monarch. Jason or Chris, this is yours.
Larry, thank you for the great introduction. So from Oklahoma all the way to the state of North Carolina, we're going to talk a little bit about same-day access to services. We are Monarch. We're a nonprofit agency that covers 60 counties in the state of North Carolina. And one of the things that we saw was a need for access to services not a week from now, not 2 weeks from now, not even 2 months from now, to see a therapist, to see a psychiatrist, but the same day that they actually need and want help. So one of the things that we tackled about 2 years ago was how do we create an environment for same-day access of services. And so that was one of the driving questions is, how do we bridge that gap? How are we able to come up with a system? How are we able to build a philosophy within our agency so that we can get people seen within a shorter time frame. And one of the things that we've developed is an open access model. We had been in National Council Conference where we had heard and seen about the open access, and then we took that information and brought it back to our agency and then tried to figure out how we were going to apply it. As I'm sure a lot of you guys know out there, it might be great in theory, but then the application of it, having all of the challenges that come with seeing people in the same day is one of those things that we had to figure out and overcome. So one of the things that we had to look at was, what is actually open access? What does that mean to us, to the individuals? One of the first things that I can tell you is you have to have people walk through the door. So I wake up this morning, I'm feeling depressed, I'm ready to talk to somebody. What do you have to do? You have to create the access for somebody to have that opportunity to walk through the door and to feel like they're going to get the help and need that day. So from that point, they are then going to go into what we call as a triage status. So they're going to fill out a triage form where they're going to list their basic demographic information. They're going to list what are they there for today? What is their reason for them coming in? And then we're going to be able, from that point, be able to dictate whether they're routine or urgent or emergent, so that, and we're going to talk a little bit later in our presentation about how we're able to take that routine, urgent, emergent and where they fit in our system. After they complete the triage form, then of course they're going to meet someone who's going to take their insurance information, going to do the intake. They're going to work through the paperwork and kind of give them a kind of an overlay of what this process means and what it's going to look like and what to expect, and potentially any costs that they may have, or potentially, what their treatment could look like over the next couple of weeks, because most of the time people who walk in, they have no idea exactly what they're walking into. So after intake, we then set the individual up to see one of our licensed therapists to complete a comprehensive clinical assessment. Our average time frames that we are currently seeing in our system for a CCA is about 57 minutes. The individual, that's our expectation is they're in that process for that amount of time. From that point, based on whether or not they are, medically necessary to see a psychiatrist, we will then route them to go see a nurse. Well, they will take vitals, have all of the PQRS measures gathered at that point, and they will go in and see a psychiatrist same day. And then at the end of that, for a psych eval, and then at the end of that, then they will proceed to, if they need, they will walk out in hand with a prescription. And so that process in of itself, our goal is door-to-door, 3 hours. Sometimes we hit that mark, sometimes we don't. It's something that we're working towards. We have to have benchmarks, so that's our goal. Our psych evals are on average taking anywhere from about 32 to 34 minutes to complete. So from that point, from an internal perspective, we had to look at, what does that mean from an IT standpoint? What does that mean from workflows? Because all of this has to be handled seamlessly for it to work, for you to be able to handle people who walk in the door same day. And it is definitely one of those things that we end up having to juggle and to figure out. So one of the things as we were building it from an IT perspective and integrating our electronic health record to be able to handle our open access model, is we had to figure out who was going to be on that team, who was going to be at the table developing what it was going to look like. And so, anywhere from, sure, operations, finance needs to be involved, your nursing staff, your electronic health record, whoever, your IT development department needs to be involved in that, because every single one of those, QM needs to be involved, every single one of those systems has to be at the table for us to be able to figure out exactly what it's going to look like in our system. And they all have a place at the table, and working as a team, we're able to figure out exactly what our model needs to look like. So one of the things that when we first started open access is we had challenges of workflow. We didn't have an implementation model, so we ended up tinkering with the system, seeing what works, because not everything worked the same way in each location. We had some rural counties, we had some urban counties that made it open access. The workflow was a little easier, but the challenge was the volume was more. So one of the other big things is, okay, what happens to the individual after the triage is determined? How do we know which staff that they need to be linked up with? How are we going to be able to access the records from the triage form? Or even when they go to see the psychiatrist, the comprehensive clinical assessment, because that time frame could be 30, 45 minutes after seeing the therapist. And so that quick turnaround of getting that information into the system. And then, as we all battle, I think in this industry, that's a lot of labor to coordinate those services. You're talking to front desk staff, you're talking to a referral coordinator, a therapist, a nursing staff, and a psychiatrist. And so trying to coordinate all of those services is something that was definitely a challenge, and we needed all of those individuals around the table to try to figure out. So for Monarch, we currently have 19 outpatient offices where we perform open access. So we are open 8 a.m. to 3 p.m. for open access. And so we're in rural areas where access to doctors and clinicians can be tough at times. So one of the things that we have had to do was figure out how we were going to get these individuals seen. And so one of the ways that we've been able to do it is we developed internally a system that we call Oasis. And so this was a custom utility that we designed. And one of the best ways that I can describe it is it's like an airplane terminal. So we have an individual sitting in an office in Charlotte, North Carolina. And we have somebody sitting in an office in Raleigh, North Carolina. We need to know exactly where these individuals are in the system so that we can get them seen and so that we can make open access work. So this Oasis custom utility that we use is a way for us to be able to track the progress of the individual. We know where they're at if they're intake. We know that they're with the referral coordinator completing their intake paperwork. We know that they're in a CCA session with a particular therapist, so we know what location is serving them. We know where they're at in the psych eval process and which doctor is seeing them. And we're able to see these individuals and provide open access by using a combination of individuals that the therapist may be on site, the doctor may be on site, or they may be providing telemed capabilities to the different locations. We've been able to create a hub model where we actually have, where it's easier to recruit. We have a pocket of teams of licensed clinical social workers and doctors who are in one location, and they telemed out primarily to our rural areas so that we can get individuals seen, because it's easier to recruit in some of the larger cities. So while Oasis has definitely been able to help us to be able to handle our workflow issues across 19 different offices and get people seen. We still, as an agency, still found that we were still missing some parts. And one of the things is timely access to the electronic health record. So you can imagine that if we're keying information in our OASIS system, which is a homegrown product, and it's not being directly inputted into the electronic health record, that data integrity is going to be an issue. You're going to have people who get busy and they can't complete the entry into the electronic health record because it's in OASIS. And so one of the things that we're hoping for is that integrating OASIS into our electronic health record will create a single data entry and will also create an efficiency of processes. And I'm going to turn it over to Jason Cagle, who is our hitman, our head of our HIT manager, and he's going to talk a little bit about how we're integrating OASIS into ECHO.
Thanks, Chris. So guys, if you listen to both Larry and Chris talk, the center point of the things they're talking about is IT has such a major role in pushing forward the clinical services that we provide today. No longer is IT a secondary thought. It's one of the primary solutions to figure out how to provide service better clinically. And so, Chris started talking about our OASIS project and how we developed this in-house software model to check people in and out and see where they were in that triage status and getting them ready to see a therapist or psychiatrist. And that's all great. It's great to see where people are. You're getting them in. You're seeing how long they're waiting, and all those things lead to great outcome measures if you calculate that data correctly. But like Chris was saying, there's still something missing, and the piece is missing is that follow-on therapy, that follow-on clinical aspect of it, which leads into the integration into our electronic health record. And that's the stage that we're at right now. We're pushing those pieces from the check-in module to actually direct access into the electronic health record. And part of that is you're trying to cut down what Chris was talking about, where there's so much paperwork getting pushed back and forth, and you have somebody who's being seen in Raleigh, North Carolina, seeing a psychiatrist in Charlotte, North Carolina. Well, that information's got to move, and it's got to move fast. And so beyond just seeing that the person's there, you need that triage information. You need the triage information loaded quickly, or else those therapy sessions or that assessment takes a lot longer. And so we look into one of the things that helped us is the flexibility in our electronic health record. We have the ability to customize screens and create modules within inside the system where once we capture the data inside our OASIS module, we can transport and bring that information directly into the electronic health records. And it allows us to get into the point where we can start validating some of that information. And that's probably the key piece. It's having an IT perspective look at things. It's always interesting when we talk about, this is the assessment form. This is all the information we want to capture. If you look at this form and it's on paper, it's beautiful. And if you want to modify it, it's so simple and easy to modify that Word document. But once you get into actually putting it inside the electronic health record, then you got to start looking at the actual workflow and the validation of the information that's there. It's not a simple click and remove anymore on a Word document once you move into that electronic health record. And so you really have to look at how that information is going to flow. How is it going to come into the system, and are you going to validate that information? And what's nice about the system we're using right now is once I start integrating the check-in sessions that are coming in through OASIS, putting it inside our electronic health record, I can validate that the names match, that the spelling is correct, that the locations match, to ensure that data integrity. And, with those workflows and the validations, then you start getting into the reports and trying to report, well, what are you really trying to get at? The hot buzzword all around this industry today is really about the outcomes and trying to get the information out of the system to validate how well you're clinically serving the people that need your support. And so you want a system that's flexible. You want to be able to modify your system so that the information that's being put in there, you can get your proper outcomes out of it. You can see, are you providing good clinical aspects? Are you reaching the people in a timely manner? And that's what we're after. And some of the data elements that we started looking at was, one, how many people are we seeing? How fast are we seeing them? And we'll pass this over to Chris real fast, and he's going to talk about this, some of the productivity that we're looking at, because that's probably a piece that's, you want to make sure that your therapists and your psychiatrists are able to constantly, see people, so you're not sitting with a lot of no-shows and a lot of time that's not filled up. And this is where, our open access model, our Oasis software helps to lead into that. And so, Chris, would you?
So let me talk a little bit about the chart that's up on that you're looking at right now about therapists and psychiatry productivity. And Jason's 100% correct. Is the ability to do open access and have that flexibility has enabled us and our agency to be able to increase therapists and productivity, because if they have a no-show for somebody who walks in for an individual therapy appointment, all of our therapists are trained on how to go into Oasis and claim an individual who may be waiting to get a comprehensive clinical assessment. So we have the flexibility now where we're able to fill that gap that normally would be a no-show of someone coming in, and as an agency, no-shows are a struggle, and we're trying to fill those and potentially backfill those appointments. Well, the open access allows that therapist to see the individual, to get them a comprehensive clinical assessment, and at the same time hit their productivity marks. And the same thing is correct for the psychiatrist as well. And so one of the last things I want to talk about before I give it over back to Chris is that where are we at as an agency now? We haven't perfected it. We are still working through our workflows. We constantly, as management, work with our local sites to enable our staff to get more efficient in what they're doing. One of the things with bringing Oasis into and merging them with the Echo and having those systems talk is we're able to analyze the data elements, and we get reports on a daily basis so that we can make real-time process changes.
Part of that real-time stuff, we're actually modifying some pieces in our Oasis system now, as well as in our electronic health records, to start capturing more information about the service we're providing to pass back to the state. The state is asking some more information about our level 4 services, how long it takes to triage somebody, how many people are actually walking in the door. And, there's the one thing about our industry is there's always this constant change. There's always an insurance provider that's asking for more information. There's always the state or the county that wants some more information about what you're doing, how you're doing it. And so we're actually creating some different integrations between the systems so that, we can track that routine session when it goes through and what happens after that. Or even when somebody comes in emergent and they actually pass on to our level 4 centers, what happens when we finish trying to process them and give them that clinical treatment? Where do they go from there? Do they just go home? What's their home environment like? And that's information that we're able to track inside both our OASIS model as well as our electronic health record. So that's about all the time we have for now. We're going to pass this over to our moderator, Chris Williams. Chris, if you could take us into our discussion timeframes.
Sure, Jason. Thank you very much. Chris, thank you, and Larry, thank you as well. So what I'd like to do now is have an impromptu conversation and drill down a little bit into some of the information that you folks shared. And my first question is, and this is for all three of you, but Larry, I'll ask you to address this first. Traditionally, in any organization, but particularly in behavioral health, when thinking about how you can provide better care or expand your coverage and all of that, develop any sort of a strategy for your organization, traditionally that was something that the administration put together with the clinical folks and drafted a plan and an idea, and if any sort of technology was needed to execute it, the folks in administration would think, well, maybe we need some technology to do this, and then turn the ideas over to the folks in IT and ask them to, okay, make this happen. At what point, given the work that you folks do, at what point did you realize that you had to have that technology was at the center of your strategies, and you had to have somebody on your IT team or representing IT at the table as you were creating and brainstorming and developing these plans?
I think that we look at traditional mental health care, and it's where the consumer used to come to the clinic, they would receive their services, and then they would go back home. And then we started looking at going to the consumer's home and providing services. And as we have different people needing different services, and with the efficiency that we must come up with, and with the Affordable Care Act, what we recognize is IT need to be in the very beginning, because we have got to figure out a different way of providing high-quality services to the consumer where the consumer is. The only way to do that is technology, and I relate it to the difference between the Pony Express and the telegram, and then the difference between the telegram and the telephone. We are emerging into a time to where our technology is so great that all we have to do is think about what we want, have the right people in the room, which of course has to be technology people that understand how to make that happen. And then they can tell us, and they help us think differently about how we can provide high quality behavioral health services to people either in their home, in homeless shelters on the street, in the prison system and the jails, wherever we may need to provide those services. Technology will allow us to do it. If they're not at the table in the very beginning, then you will miss listening and being able to hear that good idea that comes from that type of brain process that technology people have, which is very good. I'm not putting that down at all, Jason. Have you got any comments about that?
Thanks, Larry. You know, we, as IT guys, we always love being at the table. Like I said, we're so used to being that guy hiding in the closet, programming things, and being underappreciated. It's nice coming to the table and actually being part of the team and thinking things through from the very beginning of it. Sometimes it's quite difficult. We'll pass the plan and say, okay, go make this happen. And we look at it, and there's just, you know, the plan doesn't really fit in a digital world. It's great if it was all about paper and processing that through, but, you know, so it takes, you know, from my perspective, if we're not at the very beginning of the process, it takes double and sometimes triple the time to actually implement something. But if we start from the beginning, think through it from a technological aspect, because that's the way the world is going today. I mean, you're right when you're talking about the whole telemedicine piece of it. You're seeing people in their homes. at community centers, at shelters. And, no longer is it just a brick and mortar environment where somebody just walks in the door. And the only way to handle that, especially in these rural areas, is through technology. And so, yeah, we, as IT guys, we definitely appreciate being at the table right from the beginning.
So let me ask this, Jason. Can you give us an example where having you at the table as when Monarch was looking at its moving into its open access model, can you give us an example of you were able to provide a plan to do even to do something even better than the original idea was, and say, okay, that's a good idea, but you know what? We could do it even better if we did it this way.
So I know, Chris, you directed this at Jason, but I can speak a little bit about that because Jason's all the time telling me, going, what are you thinking? Of course I can do this. I can do it better than what your thoughts are from an operational standpoint. So, and I think it's been a great relationship between operations and having somebody like Jason who in our IT department gets the vision, gets the overall understanding of what we're trying to do from a clinical services and what we need to capture and why we're doing it. And then Jason's magnificent brain can figure out how to make it happen inside of our electronic health record. And that's how we've been successful in transforming our open access model, is that, thinking outside of the box and always having IT at the table. But that also comes from my perspective from an operations standpoint, is understanding IT. It's not can we do it, it's how are we going to do it. Can's not even in the vocabulary. It's how can we do it in our system to get what we need so that we can look desirable to people who want to fund us for particular operations and what we're doing, especially for open access. And so, I know I stole Jason's thunder a little bit and he can jump in here, but I'm very appreciative of an IT staff here at Monarch that definitely sees the big vision and is willing to work with us to bring outcomes of what we're doing.
So let me steer this over to Larry. Larry, can you talk a little bit about, you and I have had this conversation before, incorporating technology and investing in an IT staff can appear cost prohibitive up front. Can you talk a little bit about how overcoming that upfront expense really pays for itself in spades over time with regard to different sorts of services and opportunities you can provide to your community?
Yeah, I think that as operations and finance, and you bring everyone to the table and you start talking about what's needed, and then you start talking about how you're going to get it done. And dollars always comes into the picture. The return on investment is remarkable how quickly the return on your investment can happen. However, getting the investment in the first place can sometimes be an issue, which, I think several years ago we looked at leasing, we looked at different ways of getting the technology that we needed. Today what we do is we decide what technology we need and then we go get it, because our return on investment has been very good to us, and we're able to do those things. Now, I'll just give you an example of the iPad in the home. Somebody says, how can you afford to put an iPad in a client's home? That if you have a client that is a high-risk client that lives way out in the country to where, and if you're paying mileage to go see that consumer, or you're trying to get that consumer to come in, when you start taking $1,000 miles a month that you're traveling from a consumer, that not only do you have the clinician time tied up for that 1,000 miles that's driving, you also have about $570 in mileage that you're paying. And so it only takes 1 month of somebody driving 1,000 miles to go see consumers to pay for an iPad to where they can have an iPad in that consumer's home, and several of those consumers' home. I think we have 30 iPads out right now that are being tested in this type of manner and looking at the return on investment. So technology is not expensive. It is expensive, but it is not as expensive as the cost of personnel, the workman's comp, the travel, all of the things that happens to people when they're on the streets and when they're trying to get to the consumers on the streets, when there's another way of doing it. And that technology is what allows it to happen to where you don't have all the risk. It's not going to be for everyone, but the 20, 30, 40% that you can eventually, the high-risk consumer that doesn't end up going to the emergency room because they can touch a camera. You can't put an iPad in somebody's home with all of the information that's available to do with an iPad because the data plan would cost you a fortune, but with the right IT, the right concept, the right thinking, with the right IT people at the table, they will tell you that you can take everything off of that iPad except the camera, and they can only use it for that, and that's what it's there for. It's there for a health. It's there for health treatment, a treatment for their mental health issues, and a treatment instrument, not necessarily something to get on the internet with. So then there's always the risk of that disappearing. But these are just some of the things, and the iPad I focused on because I find that such a fascinating way of doing business, and I know that Jason and Chris both are interested in some of that because I visited with them. Any comments, Chris? Or Jason?
Yeah. So one of the things from our perspective is it's a little different, except technology and having the IT department. And one of the cool things that Jason's been able to do in our electronic health record is we've been able to get our denial rates for sending out our bills to our various funders down to less than 5% in most cases. And one of the things that we're doing is Jason's group and his IT department are creating triggers in our system or daily error reports for our staff that they go and correct before the billing ever even gets out the door, so that we're not wasting time. We're not having finance staff to have to track down and rerun and resend up bills because we're getting paid the first time it's being sent out the door. And so our rate of return on that and that investment in that IT staff is developing those, having those tools developed inside of our electronic health record to enable our field to fix the issues on the front end. So I'll let Jason maybe speak just for a second on how they're able to do that.
Well, that gets into the whole, workflow and validation piece. Everybody has a different idea about how services should route to a system. And that's the beauty of IT coming to the table, because if you have a clinician talking about how services should route through, and then you have your operations guy saying how services should route through, then your finance guy or girl talking about how services should route through and how the bills should route through. We all have different ideas, and what your IT person should be able to do is to pull all that together and figure out how to put those validations in place so the right person is fixing the services or entering the services, applying the services or the bills or correcting errors at the right time. You never want that stuff to just be stuck on the back end. And that's the IT piece. I love Larry talking about the whole iPads and what you can do with it, because you're talking about truly putting technology in somebody's home, and there's so many different ways you can apply technology to the services we provide. And I think the key piece is getting everybody on board with it. It's kind of funny listening to Chris and Larry, who are operations guys, and they said they keep saying get that IT guy there and talk about it, because it absolutely is important pushing those ideas through on the front end.
Before we turn it over to our audience questions, one final thing. I'd like each of you to briefly share with me what you think the future of technology, what technology does to the future of behavioral health care. What do you see coming in the next 1 to 5 years? And Jason, I'll let you kick that one off.
Man, that's like on the spot. Listen, I like this question. We talk about where we were, straight brick and mortar. You had to drive to some place, or a therapist or psychiatrist had to drive for hundreds of miles to see somebody. So we're bypassing that. Now we're starting to get in where you can have iPads in somebody's homes, and even that piece can get a little bit difficult based off the high-speed internet that's available. So you got companies like Verizon, FIS, Google, who are putting fiber out all throughout the U.S. And a lot of these companies are putting free Wi-Fi throughout rural areas. And so you start mixing that in with an iPad, and then you can get into things that we call like RFIDs, which are like little scanners that can they can actually link up to an iPad. You can use that technology now. It's used a lot in the medical industries to start scanning somebody's like their blood pressure, their heart rate, and those kind of things. You start combining that with the iPad, linking it back through electronic health record, and right away it's not just telepsychiatry anymore. It's like you can really see the questions that you're asking, how it's affecting that person's heart rate. And that gets you to a different idea and a different understanding of where to take those sessions. And to me, that's probably some of the coolest stuff that's going out there, is just that ability to better communicate and better see the responses, both mentally and physically and emotionally, of the people you're trying to support.
Chris, what do you think?
Sorry, I was working on getting off mute there while Jason was on his. I love the fact, and Larry and I had a great conversation on the phone on the airplane ride back from peer to peer about the use of iPads, and I think that the wave of the future is going to be, especially as have been trying to strategically plan, is the ability for people to sit in their homes and get services that they need, whether it's to see a doctor or whether they see a therapist, and because that's access to services at the point of when the need is there. They don't have to physically come out of their home to be able to see someone, but they're able to get the services that they need at the right time. So I see the wave of the future is going to be, smartphones, iPads. Sky's the limit. We're going to have new technology that's going to come out in the next couple of years that's even going to push the envelope even more so than what it already is. So I'm excited about where we're going to go from in the industry, where we're going to go for technology.
Great, Larry. If you don't mind wrapping this section up for us, what is in your crystal ball with regard to where technology is going to take you folks?
I think that we'll see smart homes. I think we'll see people that where all their medical services almost can be provided in their home with the right technology as we build homes into the future. And we're not that far from there. I think by 2017 to our 2020, most homes will be required to have this type of equipment as part of their as part of building the house that they're building to where people can have services right there in their home, and the everything from when you go to the restroom, it will weigh you to tell you what's in your urine, to be able to register what's going on with your body, and to looking in the mirror and being able to make that mirror turn right back into where the physician can see you and see what's going on with you, or where you can sit in your lazy boy chair and have therapy session with a good therapist through video, and our homes will be built that way. I think that's going to be that's how.
Great.
You know, it's not the
Larry,
jets. It's supposed to get.
Larry, thank you. Julie, we'll pass it back to you and let you take it home.
Okay, great. Well, it sounds like an exciting future in IT, and I'm really looking forward to it. We have had some questions come in from our audience members, but just a reminder, you can use the Q&A area to the right of the slides to submit your question at any time. And you had mentioned that the IT guys need to be at the table from the beginning. And someone in our audience is asking, what type of skills and abilities should that IT person have? This organization has seen some people who are very good at software equipment, not necessarily good with workflow and with integration with clinical work. So what kind of skills and abilities does that IT person who's sitting at the table need to have? Chris, maybe we can start with you.
So other than the fact that Jason doesn't have skills, no, I'm just kidding. I'm going to, one of the things that I think I'm going to let Jason speak to the IT skills that I think he can bring to the table. But one of the cool aspects as we sit around the table with someone like Jason is he doesn't just see the IT picture. He sees the bigger picture. We're at the table. We're working through workflows. He understands our industry and what we're trying to accomplish. That may mean he's even out in our centers. He's out with looking at workflows. He's talking to staff. He's investing the time and energy that's needed into knowing exactly what needs to happen. So it's definitely a tandem of us working together and him investing the time in the services. And maybe, Jason, you can speak a little bit more about skill.
Yeah, the skill set's kind of weird. On my team, I have guys that are software developers, they're DBAs, ones that are great with have that calm natured personality to talk on the phone and de-escalate people that are irate because maybe they got kicked out of the system 10 times. But I think if you're talking about who should sit at the table to help push these decisions through, I mean, it's really a generalist. There's guys like me who've been in the industry for a long time, and I've done anything from networking to web design to security to pushing out and implementing electronic health records. And so I've seen a lot of different things, and I think that's the type of guy that you need to have at the table, not necessarily a specialist. You need somebody who can communicate with your operations guys, who can communicate with your clinicians, and who can take that and pass it back down to your specialists, who would be your software developers or your DBAs or your network guys that could who could modify the networks to support iPads that are going out the door. I think it's one thing that's about us IT guys is we're typically a little bit introverted, and so you definitely got to have somebody that can sit at the table and have that extroverted communication with the therapist, with your operations guys, with your doctors to be able to pass that back down to the specialist.
So true. Well, thank you so much for your insight on that. Unfortunately, that's all the time we had for questions today. Time went fast. But I do want to thank Chris Thompson, Jason Cagle, and Larry Smith once again for a great presentation. And I would also like to thank our sponsor, the Echo Group, for making today's program possible. Finally, thank you to everyone in our audience for participating today. We do hope you'll join us again in the future for another behavioral healthcare webinar. This concludes today's presentation.